Now I have the pleasure to introduce Lars Rejnmark, which is a clinical professor of endocrinology at the Aarhus University and serves as a consultant at the Department of Endocrinology and Internal Medicine at Aarhus University Hospital. He has published more than 300 papers in peer-reviewed journals focusing on calcium homeostasis, the vitamin D parathyroid axis, and bone metabolism. Rejnmark has participated in drafting the European Society of Endocrinology clinical guidelines on treatment of chronic hypoparathyroidism in adults, as well as drafting guidelines on pseudo-hypoparathyroidism, X-linked hypophosphatemia, and primary hyperparathyroidism. Rejnmark has previously served as a clinical focus area led by the European Society of Endocrinology on bone and calcium disorders, and the co-chair of the main thematic groups on calcium phosphate and disorders in the European Reference Network on Rare Endocrine Diseases, ENDO-ERN. Thank you very much, and very curious to your talk.
Yeah, thank you for this kind introduction. Yeah, thank you for inviting me to give this talk on use of teriparatide in patients with hypoparathyroidism. These are my disclosures. As you probably know, hypoparathyroidism is hypocalcemia due to low or inappropriately low normal PTH levels. It's a rare disease, but despite being rare, there are probably around 200,000 patients in Europe, 120,000 in EU with hypoparathyroidism. So there are many people actually suffering from this disease. The disease is normally divided into post-surgical and non-surgical hypoparathyroidism, but these two types of the disease are treated in a similar manner. It is called chronic if it lasts for more than 12 months. The mainstay of hypoparathyroidism is conventional therapy in terms of calcium supplements in combination with activated vitamin D analogs, thereby normalizing plasma calcium levels. And the goal of conventional therapy is to achieve plasma calcium levels low in the reference range without having symptoms of hypocalcemia. But hypoparathyroidism is a complicated disease. It is more than just normalizing plasma calcium levels by supplying activated vitamin D and calcium. Despite near normalization of plasma calcium levels, patients often have fluctuations in their calcium levels, and these fluctuations are often unpredictable. Patients have other biochemical disturbances, including hyperphosphatemia and hypercalciuria. They often have an impaired quality of life with a high pill burden and increased risk of several complications. And these complications has been demonstrated in rather a lot clinical trials showing that these patients with hypoparathyroidism, they have an increased risk of renal insufficiency with nephrolithiasis. They often have neuropsychiatric diseases and an increased risk of infections. Also, they have an impaired quality of life. There's been many studies showing this impaired quality of life in patients with hypoparathyroidism, including this study in 264 patients with hypoparathyroidism, showing that these patients, they have loss of vitality, pain and cramps, and often had numbness and tickling sensations. And somehow it was found that females had higher burden of symptoms than males. And recently, within the last months, additional studies have been published showing an increased risk of cardiovascular diseases in hyperparathyroidism, as well as there's been a study showing an increased risk of vertebral fractures, although there was a decreased risk of hip fractures in patients with hypoparathyroidism. So despite obtaining near normal plasma calcium levels in response to conventional therapy, hypoparathyroidism is associated with multiple complications, and therefore it is highly relevant to try to improve the treatment of these patients. And actually, hypoparathyroidism is the last of major hormone deficiency states, which is usually not treated by substitution with the missing hormone. Actually, there has been an option to treat patients with hypoparathyroidism with PTH. It was marketed in the EU in April 2017 called Natpara. And this treatment, it did help to normalize plasma calcium level. It increased renal excretion of phosphorus, thereby lowering plasma phosphate levels, as well as it improved the well-being of the patients. But Natpara was discontinued by the end of 2024 due to manufacturing and supply issues, and therefore it was no longer possible to use this treatment in hypoparathyroidism. Also, PTH has a short duration of action. This figure shows the plasma PTH concentrations in response to an injection, subcutaneous injection with PTH. And as you can see, PTH levels are increased immediately after the injection, but it does not last that long. So by the end of the day, there's no more PTH present in the circulation. And furthermore, these fluctuations in PTH level cause pharmacodynamic effects, pharmacodynamic fluctuations with swings in plasma calcium levels during the day. And this is not a very physiological approach. Studies have also been performed on treatment with PTH 134 as subcutaneous injections or by pump delivery. This figure shows that in response to a subcutaneous injection with PTH 134, we, similar to injection with PTH 184, see this rise in plasma calcium levels shortly after the injection, but this increase in plasma calcium levels does not last throughout the day. If you inject PTH 134 twice a day, you have less fluctuations in plasma calcium levels, but they still occur. If you use PTH 134 by pump, providing PTH 134 by pump infusions, you see that there are almost no fluctuations in plasma calcium levels. And furthermore, PTH provided by pump therapy lowers renal excretion of calcium, and it lowers the need for PTH. The dose in response to pump therapy was significantly less than what was needed if PTH was injected once or twice daily. And furthermore, if asking the patients, they prefer pump therapy instead of daily injections. Palopecteriparatide, previously called Transcon PTH, is a drug developed in order to provide sustained release of active PTH 134 throughout the day, 24 hours a day. Palopecteriparatide is PTH 134 bound to a carrier protein through a linker, and in response to subcutaneous injections with palbociclib peroxide, this linker is cleaved and PTH is released from the carrier molecule and able to interact with PTH receptor. And the carrier molecule is excreted through the urine. Several studies have been performed to show the effect of TransCon PTH. Not at least a phase 2 and a phase 3 trial have been published. The phase 2 trial was included 59 adults with chronic hypoparathyroidism, and they were randomized to 4 weeks of double-blinded treatment with a fixed dose of TransCon PTH or placebo. And the primary endpoint was normalization of plasma calcium levels being independent of active vitamin D and requiring less than 1,000 milligrams per day of calcium supplements and a reduction in the renal excretion of calcium. And this primary endpoint was achieved by 50% of the patients treated with TransCon versus only in 15% of the patients treated with placebo. And this was a significant effect on the primary endpoint. In the subsequent study, the phase 3 trial, 82 adults with chronic hypoparathyroidism were randomized in a double-blinded manner to treatment with either TransCon PTH with a starting dose of 18 micrograms per day or placebo, and the dose were adjusted aiming at normal plasma calcium levels. And this double-blinded design was continued for 26 weeks, after which all patients were transferred to treatment with TransCon PTH. The primary endpoint in this study was normalization of serum calcium and independence from calcium and active vitamin D. And as you can see in this trial, this primary endpoint was also reached with a significant difference compared to placebo. This study showed that in response to treatment with palbociclib, 93% of the patients achieved independence from therapeutic doses of calcium. 98% achieved independence from treatment with active vitamin D, while plasma calcium levels were maintained within the normal range. This treatment also caused a reduction in the renal excretion of calcium, lowering urinary calcium significantly compared to conventional therapy. In addition, quality of life was improved in response to treatment as assessed by the SF36 questionnaire. As you probably know, in this questionnaire, a higher score is better. And as you can see in this figure, in response to treatment with TransCon PTH, SF36 scores improved, increased compared to placebo. And after all patients were switched to treatment with TransCon PTH at week 26, those who started treatment with placebo increased their quality of life in response to TransCon PTH. In this study, another questionnaire was used, the HPES questionnaire on quality of life, and it showed that in this questionnaire, a lower score is indicative of an improved well-being, and the study showed that in response to treatment, the HPES symptom physical domain score decreased, so did the cognitive domain score, as well as there was a decrease, indicating an improvement in the physical function domain score and improvement in the daily life domain score. Bone mineral density and bone turnover markers were also assessed in this study in the 61 patient randomized to TransCon PTH at baseline. And as you can see on this slide, bone turnover markers increased in response to PTH treatment, reaching a peak for the CTX bone marker of bone resorption at week 12, while the marker of bone formation P1 and P reached a peak after 26 weeks of treatment, thereby normalizing bone turnover compared to conventional therapy. And in conjunction with this increase in biochemical bone markers in bone turnover, there also was a decrease in bone mineral density at the lumbar spine and total hip. You may say that bone mineral density normalized, as this is normally abnormally high in patients with hypoparathyroidism. Kidney function improved in response to treatment with palbociclib. As you can see on this figure, in response to the treatment, there was an increase in eGFR, while the patients who initially were treated with placebo increased their eGFR after being switched to treatment with TransCon PTH. Patients were divided into those who at baseline had an eGFR below 60 mils per liter or above 60 mils per liter. And the treatment improved eGFR in both group of patients. But in those with an eGFR below 60 mils per liter, the improvement was more pronounced than in those with an almost normal kidney function at baseline. There were adverse effects in response to this treatment, but none of these adverse effects caused the participants to stop the treatment. And of course, there were some who had injection site reaction, which is not that surprising. So overall, treatment with palbociclib seems to address some of the issues in the treatment of hyperparathyroidism. It causes stable plasma calcium levels, decreases the renal excretion of calcium, improves the quality of life, improves kidney function. It increases bone turnover, which causes a slight decrease in bone mineral density. And this treatment has been approved by EMA, FDA, and other health authorities for the treatment of hypoparathyroidism. It is provided as an injection pen similar to insulin. The injection pens come in 3 different strains, allowing a daily dose of between 6 to 30 microgram per injection. And most patients do well with 1 injection. However, some need doses higher than 30 microgram, so they will need to have 2 injections to get this dose. And the dose range allowed is 60 to 60 microgram per day. So that's what I had planned to say. So thank you for your attention.
Thank you so much, Professor Rejnmark, for your outstanding presentation. Really interesting. And I think we have time, kind of 5 minutes of time for questions to you. So I can maybe start. So you have showed that the administration of pyrrolopectin is associated with an improvement of renal function. And I would like to know what is the potential mechanism underlying this improvement.
Yes, thank you. And that's a very good question. Probably PTH affect the hemodynamic of the kidney. So the hemodynamic may be improved by providing PTH. But I believe that further studies are needed before it's possible definitely to tell what this improvement in kidney function is caused by.
Okay, thank you. So we have a couple of questions here from the audience. So one colleague asked if the long-acting is approved in children.
Yes, thank you. No, not yet. As far as I know, the company has planned to do studies in children in order to get it approved for pediatric patients. I see no reason that it should not work and be beneficial to children, but at the moment it is only approved in adults with chronic hypoparathyroidism. So time will show.
Yes, yes. And then another colleague asked if this agent has been included in the ESE guidelines as a recommendation.
Yes, in the updated ESE guidelines, which hopefully will be published very soon, it is recommended that patients who are not well treated with conventional therapy should be treated with this pyrrolopectin, or at least a long-acting PTH analog, because short-acting PTH analogs just injections with PTH 134 or 184 is not sufficient.
Okay, and I have a question. So are there any data on the safety of the switching from teriparatide to pyrrolopectin? And if are there any practical advices and recommendations that can be given for the switching?
Yes, that's a very good question. I believe that recently there was a study published on switching patients from Natpara PTH 184 to pyrrolopectin. It was published by Heide Sigelkopf in Germany. And as far as I remember, the result of the study was that it's very difficult to predict the doses needed of pyrrolopectin when people are switched from PTH 184 to PTH 134. You just have to look at which dose did they receive beforehand, 100 microgram per day, and then start them on a medium dose of pyrrolopectin. But it's difficult to predict.
Okay. Another colleague asked if there are any differences in the outcomes in surgical patients versus non-surgical patients, and if what is the effect of intracranial calcification incidence compared to usual treatment?
Yes, thank you. That's a very good question. It's very interesting. The hope is, of course, that providing patients with PTH, which they are missing, will reduce the risk of these long-term complications, which has been shown in patients on conventional therapy. But at the moment, we do not have any long-term data on whether this pyrrolopectin treatment actually will reduce the risk of these long-term complications, including intracranial calcifications. And I believe you also asked if there is any difference between post-surgical and non-surgical hypoparathyroidism. as you know, so far only rather few patients have been included in these trials, the phase 2 and the phase 3 trial. It was not much more than 130 patients in total. So it's too early to tell whether non-surgical and post-surgical should be treated differently. But as far as our data at the moment, it seems that there is, at the bottom line, no difference between post-surgical and non-surgical hypoparathyroidism in how they should be treated.
Okay, another colleague asked what to do with the active vitamin D and calcium dose once starting this compound.
Yeah, thank you. There is an algorithm on how to start the treatment with palopectin paratype. The algorithm, as far as I remember, suggests that when you start the treatment, you should halve the dose of active vitamin D and then measure calcium levels after a few days, and if it stay within the target range, you can reduce the dose of active vitamin D further. But there is an algorithm which comes together with a drug which I believe can be used.
Okay, and just the last question, a quick answer, please. Is there any data on loss of efficacy due to anti-palopectin antibodies?
As far as I remember, antibodies were detected in response to the treatment, especially to the linker which binds PTH134 to the carrier molecule. But none of these antibody were neutralizing. So it does not seem that they have any effect on the effect of the treatment.
Okay. Thank you so much again for your wonderful presentation.
Thank you.